Good afternoon, everyone, and welcome to the DiaSorin Molecular Workshop at the 2018 AMP meeting. So first of all, happy Halloween, and thank you all for joining us late on this Halloween afternoon. You'll see that Dr. Martinez, one of our speakers, has decked out a bit for Halloween. So I first have to tell my Halloween story. It happened on Monday because we had an all-employee meeting, so all of senior management was dressed up. I was dressed up like Madonna, if you remember, like the lucky star, like the big black bow in the hair, etc. Was driving to work, and then I was the front car in a 5-car chain reaction accident. Okay, I'm fine. I was stopped at the time, but Highway Patrol eventually got to me over on the right-hand side, leans in my window, and I said, "I'm so happy to see you," asked about insurance and all that, and then he said, "I just have to ask, what's up with the outfit?" I said, "Okay. It's Halloween at work today." So anyways, that's my Halloween story. Not dressed like Madonna right now. But I'm Michelle Tabb. I'm the Chief Scientific Officer for DiaSorin Molecular. And it's my pleasure to introduce our two workshop speakers today. We have Dr. Wallace Greene from Hershey Medical Center, who will talk about Pneumocystis jirovecii and use of our brand new ASR primer pair. And then Dr. Raquel Martinez will talk about our Simplexa Group B Strep assay. But before we get there, I wanted to say a few words about our system and also the assays that are currently available on the system. So for those of you who have not seen it, this is our technology. Here's our instrument and system. And this was the 3M integrated cycler under Focus Diagnostics. We were acquired by DiaSorin about 2.5 years ago now, and the instrument has been rebranded the Liaison MDX. So this instrument and our technology, including the discs that we have available, really position us very uniquely within this industry because it's a single instrument where multiple discs can be used, and we have IVDs and user-defined. We have low throughput or moderate throughput, sample to answer. We have the high throughput 96-well disc. So really ultimate flexibility that is very unique in this industry. The technology in terms of the chemistry was developed by DiaSorin Molecular in Cypress, California, and the disc technology was developed by 3M. But you can see here on the left and right are our two discs. On the left is our direct amplification disc, which we use for sample to answer testing for 1 sample up to 8 samples. And we'll talk about the assays available in that format next. And then we have our original universal disc, which is for 96 wells, up to 96 wells of testing, 10 microliters of reaction volume for that high throughput need in the labs. So we have both ASRs and kits, as I mentioned, IVD and user-defined modes. So in terms of the currently available menu of Simplexa kits, on the left-hand side are the ones that run on our 8-well direct amplification disc. So this is all sample to answer, CLIA moderate complexity in the United States. And I'll start with the assay on the very bottom. Group B Strep, which you'll hear Dr. Martinez talk about, was submitted to FDA in early September. And so we are hoping for good news on that assay in the next days. It is already CE marked, so you'll be able to see all of that data in a little while. But in terms of the first assay that we developed for the disc, we have flu AB RSV. That was followed on by HSV 1 and 2, and I wanted to mention that assay because we have the broadest intended use claims of anyone in the industry for HSV 1 and 2 detection and differentiation. We have cerebral spinal fluid, and now most recently we have clearance for both cutaneous and mucocutaneous swab sample types in a wide variety of transport media. We also have Group A Strep, C. diff, as well as Bordetella. Bordetella was recently FDA cleared a couple of months back, and that assay detects and differentiates Bordetella pertussis and parapertussis from nasopharyngeal swab samples, also in a variety of transport media. And then on the right-hand side, we have our original flavors that were available on our 96-well disc. We have the flu AB RSV and, of course, the swine flu test. But I also wanted to mention we have the C. diff test in the 96-well format. We call that universal direct when it's in our 96-well format with the direct testing. Direct testing to us means, whether it's in the 8-well or 96, that no extraction is required, that you take that sample directly and add it to our reaction mix components and just begin your PCR cycling. Last but not least, I wanted to mention some of the reagents we have that are available for when customers want to bring up their own lab-developed tests on our system. So I'd already mentioned with regards to the system, we have a user-defined mode in our software, and we have more than 50 different primer pairs available for the system so people can pick and choose what kinds of assays they want to do the validation for in their own labs. And a couple that I want to highlight that are the most recent offerings here. You heard me already mention the atypical pneumonia assay that's in development. And you can see here that we have the M pneumo, C pneumo, and Legionella pneumophila already available as ASR primer pairs. And also, if you do not want pneumophila and you'd rather have Legionella species coverage, we have that too, that can substitute in. And then I also wanted to highlight the most recent vector-borne offerings, which include some Simplexa together for tick-borne infection detection. And those are namely Babesia, Ehrlichia, and Anaplasma phagocytophilum. We already have Borrelia species detection available. And then also recently, we made available Bartonella as well as Plasmodium, which is down here at the bottom of the list. So with that, enough about the system that we have available for those of you who want to develop your own lab-developed tests or the IVDs that we have in development. And I want to introduce our first speaker for today, and that's Dr. Wallace Greene. Dr. Greene completed his PhD at the University of Tennessee College of Veterinary Medicine, followed by completing his clinical microbiology postdoc work at the University of Rochester Medical Center. And since 2003, he served as Associate Professor of Pathology and Director of Clinical Virology for Hershey Medical Center and Penn State University College of Medicine. The title of his talk today is Objective, Sensitive, and Specific PCR Testing for Pneumocystis jirovecii, where he's going to talk about a lab-developed test that he developed using our ASR primer pair for pneumocystis and show us some interesting results. So without further ado, Dr. Greene.
Congratulations to everyone for finding their way down here. I had to ask twice to make it, just saying. So, anyway, here is the Hershey. If you've never been to Hershey, Pennsylvania, there are two things going on in Hershey. We have the medical center. This is Penn State's College of Medicine. Do great work there. And then, of course, this is the Hershey factory. I imagine most of you are familiar with what's going on there. Okay, conflicts of interest disclosures. I've been at this 30 years, so I've done a lot of trials, research, and a few presentations such as this one for companies. So on with it, Pneumocystis jirovecii, and this is the best that you can get with the DFA. Unfortunately, life is not always like that. This was first described as pneumocystis back in 1912 by Antonio Carini in slides that he prepared from infected rats. And for many years after that, okay, we all know about Pneumocystis carinii. It was considered to be a parasite for many years until there were studies, ribosomal RNA, the cell wall structure, and then, of course, sequencing, like everything, identified it as a fungi. Then Otto jirovecii later described the human strain, and that's why we got the name change, which I resisted for years. But anyway, that's the nice thing about being a virologist. Nobody messes with the names. But anyway, we're up to speed now. For those of you who are hooked on phonics, this is jirovecii. Okay. It took me a hard time to figure out how to say that. I found that on the internet, so you know it has to be true. This was once a very rare disease until World War II, when it became, unfortunately, very common in very malnourished infants. When that World War II got resolved, it went back to being rare until the 1980s and 90s, of course, with the appearance of AIDS. And this was the time I was at the University of Rochester, Strong Memorial, and we had a lot of patients that was suffering really, really badly from the pneumocystis. So that's where I first ran into it. Epidemiology, it is found worldwide. It's not found in nature. It's thought to be spread from human to human. We'll see here in a little bit, our strain cannot infect anything else or any other species. Following immunosuppression, up to any given time, 20% of the people may be colonized. But following immunosuppression, the illness may be either due to a reactivation or, as a lot of research has shown, maybe new infections, because you can be infected with multiple strains of the pneumocystis. It still remains to this day the leading opportunistic infection in AIDS patients. We have also seen, and this is in the literature as well, diagnosed in patients with solid organ stem cell transplants, blood cancers, and autoimmune diseases as well. And particularly important for those out there who are doing DFA, organism cannot be grown in cell culture or in animals. So it has 3 stages. We start out with the trophozoite, and we'll look at staining and what this means, what you're doing in your lab. And then this can go on. This can become the sexual form of it. It goes around through maturing in the cyst, and then finally you get a mature cyst that will have 8 of these mature trophozoites in there. They rupture, and the life cycle continues. Now, it is thought to be spread by airborne infection. Hospital outbreaks have been seen in various clinics. And there's also been infection documented of healthcare workers who are caring for infected patients. Symptoms are very generic: fever, cough, difficulty breathing, chest pain, fatigues. Some of these symptoms will develop over days or up to a few weeks. AIDS patients the symptoms tend to develop over a longer period of time. The chest x-ray, we'll see here in a minute, is interstitial infiltrates. Now, the HIV with patients with CD4 counts of greater than 200, the incidence in those patients would be less than 0.5%. However, if the CD4 count drops under 200, the incidence goes up to 18.4%. And patients who have had thrush for a number of months, the incidence can get up to essentially 30%. Complications, pneumothorax, we saw a ton of that back during the early AIDS years. Infections with other tissues, such as the CNS, GI tract, eye, skin, liver, and other sites as well. So it's not just for lungs and BALs. Mortality, 10 to 20% for AIDS patients, and it's actually now it's higher for non-AIDS patients, because AIDS can be controlled when you get onto it. The Pneumocystis pneumonia, this is the diffuse interstitial pneumonia I was telling you about. Okay, diagnosis. We used to routinely run down this gamut, and then people gave up on this first one. But you get a sputum because it's easy to get one. But it's not very sensitive, so they were pretty much all negative. The patient gets ramped up to an induced sputum. That can be anywhere from 50 to 90%. This depends upon the skill of your respiratory therapist who's doing the induction, and also the tolerance of the patient about how much they're going to put up with. But then you get down here to bronchoalveolar lavage. This is the most invasive, but by far provides the greatest sensitivity of between 90 and 99%. And I do believe that these figures are back when we were talking about staining. And with the assay that we're getting to today, I know it's a lot, well, we're going to show you it's better than what we had with the DFA. So diagnosis is usually done with stains, or at least that's how it was done when I was first starting out in the last 30 years. You have the Giemsa, and then this Rabsik Giemsa, the DifQuick. And this was kind of our go-to test when I was first got up to Rochester, because it was easy. And these patients were, these HIV patients were loaded with the organism, so this worked just fine. Again, it was quick and easy. But back on, this is looking for the trophozoites. This does not show you the cyst. I'm going to make an exception with that. This is a really cool picture. This is actually a cyst here with the 8 different nuclei that we mentioned earlier before in the life cycle, but that would be rare to find that. Okay, cysts are by far the most common target. You had the toluidine blue O. This was, again, very quick, very easy, extremely cheap, but somewhat insensitive. I certainly wouldn't recommend using that today. You've got a kind of a dark blue cyst on a light blue background. Then you have your methenamine silver stain. This is a little more complicated to perform, but it has a much better sensitivity, usually performed up in histology. That's where it was when I was in Rochester and when I got to Hershey. But we did find that the DFA was more sensitive to the silver stain, and the main reason being that if you had a patient with thrush and there were a lot of Candida organisms in there, they're much smaller than a pneumocystis, granted, but they all stain the same color. So you could easily, if you had a low positive specimen, your pneumocystis could be hiding down among all the Candida. Then there's the calciphore white. This requires a fluorescent microscope with a proper UV filter. And a lot of labs I know like this because those of you, how many people are doing DFA? Well, we used to, okay. You had a real problem with DFA finding positive control material, but with the calcifluor white, since it was not a specificity with antibodies, that was not a problem, and you could use cyst from other mammals such as rats. Then you have your fluorescent conjugated monoclonal antibodies. These are not staining the cyst wall directly, but they are staining the surface protein that will outline the cyst. Interpretation may be difficult and subjective with the low positive specimens. And of course, there's difficulty obtaining positive controls. You can't order these anywhere. You have to, when you have a positive patient, you go around and you collect all the BAL that you can find, and then you put it in your freezer and you don't tell anybody that you have it. There's a positive silver stain. Again, this was very sensitive. For a while, it was the go-to stain. But again, you can imagine if this were full of staining Candida, this could be a problem. So here's a nice strong positive DFA. You can see these cysts. Again, they're just outlined by the fluorescence. And there's no trouble calling that positive. So this is where I get to stay in my office and nobody's calling me into the lab. You get down to these, and this is a low positive. You may have to look over 2 or 3 slides sometimes to find something that looks like that, where that's clearly a cyst, and you can call it positive. And then you get these. There are no cysts present. Now, if you make maybe a half dozen different slides and you look and look and look, you may find something like the previous slide. But I know when we finished our validation with the PCR assay, we had several of these. And since it was already validated, I said, well, let's just run the PCR. And on one of them, it was a nice positive. I forget the CT value, but it was a good positive. And the other was negative. But, everybody in the lab, including me, we couldn't make a call. Okay, so at the Penn State Hershey Medical Center, the last 30 some odd years, we've been running the DFA stain. We have a very good microscope for doing that on. And also being in the virology lab and being around for a good long while, most all of my techs, at least back then, were very proficient at reading immunofluorescence. So this worked for us very well. Occasionally, though, we would get stuff that would be difficult to interpret, and my response to that, well, let's just make more slides and keep looking. As I said, it required hoarding of positive specimens. Occasionally, a friend would call, do you have any positive stuff? And I don't know what you're talking about. But anyway, currently, we are mainly, primarily now, a molecular lab. We run a half dozen of the DiaSorin assays already. So looking at this new assay was a very logical thing for us to do. So as Michelle mentioned earlier, this was a lab-developed test. It includes the primer pairs, universal mix. It's done on the 96-well universal plates. The procedure is we will centrifuge. This is not an extraction, it's just a concentration. A half mil up to 1.5 mil of sample at 12,000 Gs for a couple of minutes. Suspend the pellet in 400 microliters of PBS, and then we load up the wells, like with a lot of their assays, with 8 microliters of master mix and 2 microliters of sample, and then we run it for 40 cycles, about an hour. Okay, for our evaluation, we looked at 20 frozen known positives by DFA. Then we looked at another 21 fresh BAL specimens that were ran along with at the same time as the DFA. We did a limit of detection where we did 10-fold dilutions of a known positive, ranging all the way from undiluted up to 10 to the 9th. We looked at cross-reactivity between the test looking at Staph aureus, including MRSA, Pseudomonas, Klebsiella, Group A Strep, and H. flu. And then we looked at inhibition using mucoid and grossly bloody BAL specimens. Okay, our results, of course, all 20 of the specimens that were previously positive by DFA were positive with the PCR. Of the 21 BAL samples, there was one that PCR reported as positive that we had previously found to be negative by DFA. But when we went back and carefully reviewed that slide, there were two areas that were small areas of the cysts were found. And the CT value of this specimen was 31.1. With the inhibition study, only one very mucoid sample was inhibited due to, as you can see, by lack of internal control, and none of the bloody specimens were inhibited. And again, no cross-reactivity was detected. Now, when you look at the limit of detection, here we go, neat, CT value of 18, and then as we dilute down here through here tenfold, these go, and as you would expect them to increase. But with the DFA, you start over here, and then you get down to one zero cyst, one cyst. And the big difference between these two assays is here you're looking for cyst. Okay, over here we're looking for a DNA target, which is present in both the trophozoite and the cyst. And there are more trophozoites usually in a specimen than there are cysts. So that greatly increases the sensitivity because you have a lot more target with the PCR assay than you do with the DFA. So the advantages for the PCR testing, okay, you have greater sensitivity. I'm not sure if I made that, but look, okay, down here, depends upon where you want to take your cutoff. But, if you set it high enough, that's 1 to 10 million, as opposed to what you would see with the DFA. So if you do have a lot of specimens frozen back in your freezer, BAL positive specimens, you can dilute those out and get you all the way through retirement quite easily. With the advantages, greater sensitivity, specificity, objective resulting compared to everybody having a meeting deciding if it's positive or not. Positive controls are available. These are not the organism. These are controls that have been prepared. The gene has been placed in another, I forget the organism, but in another yeast, commonly used for these kind of things. Unlike the IFA, both trophozoites and cysts are detected, giving you greater sensitivity. And now the time required to train new technologists is much less for PCR than to become proficient with DFA. We are having some turnover, and we just don't do that much DFA anymore. We used to do a lot with flu, with RSV, skin scrapings. Now all of those are molecular assays. So to get somebody proficient with PCR, especially when you're running 6 of the other assays, that's easy. It's just a new set of primers and probes. So a little plug here for Angie Spahn. She's the senior molecular tech sitting down here. She will be presenting this poster, all this work, Friday at 2:30. So if you want to talk with her, did all the hands-on work, she would love to chat with you. Any questions? Okay, thank you.
All right. Thank you, Dr. Greene. I just wanted to mention, so for the control material, so Exact Diagnostics has this available commercially, and they cloned a part of Pneumocystis into Pichia pastoris, so that it's available. So now we have control, so that's great news. So now I want to introduce our second speaker. Yes? Yes. Oh, yeah, absolutely. I'm sorry. Go ahead.
And you may wonder why this test is coming so late to the market, and it's not even offered by many as a FDA-approved test. So my biggest question is that if you randomly go on your sputums that you saved for any other reason and test them, what's the proportion of positive rate? What proportion of them turn positive with your test?
Oh, if we ran a bunch of negatives, then we did.
I mean, they are not ordered, they're not suspicious to have that. That's the biggest question that probably the reason that deter companies to bring this as an FDA-approved test.
Okay, I see your question now. We did not go back. This is the only one of the very few years that we get the yield loss, maybe sometimes with But I do know out there is, I had this discussion with one of our infectious disease docs that, like I said, and at any given time, 20% of us could be carriers. And so what happens when you find it, it's very sensitive assay, where you can look at the CT value, and that will give you some idea how strong the positive is. And with the ID doc, I told her that just let me know when you need this, and we'll do a BFA on it. She's familiar with interpreting results from BFA. She was not with this, so that's how we're going to address that. But you're right, you could identify carriers, but I would imagine they would be in the low CT value.
But yeah, thank you very much for that.
Good question. Thank you.
Okay, any other questions for Dr. Greene? Sorry we didn't pause long enough. Okay. All right, so let's move on then to Dr. Martinez. So Dr. Martinez completed her PhD in microbiology at Dartmouth, followed by completing her clinical microbiology postdoc work at University of Washington at Seattle. And since 2013, she's been at Geisinger Medical Center, where she served as director of the Clinical and Medical Microbiology Laboratory, and then most recently as System and Core Laboratory Director for Clinical and Molecular Microbiology. The title of her talk today is Rapid Detection of GBS Direct from Sample, and she's going to talk about the performance of Simplexa Group B Strep Direct. Geisinger was one of our clinical sites for our U.S. studies. And so without further ado, Dr. Martinez.
Good afternoon, everyone. Can you hear me okay? Do I need to down? I'm short. Okay, better? All right. These are my disclosures. And our objectives today is to start off talking about the organism background and disease state of Group B Streptococcus. We'll briefly review the laboratory methods for GBS detection, and then we'll spend time talking about the performance data of the Simplexa Group B Strep Direct assay. Then we'll close with summary and discussion from the audience. So Group B Streptococcus, or GBS, is more formally known as Streptococcus agalactiae. It is a gram-positive cocci in pairs and chains. And for its colony morphology, it's mainly beta hemolytic, but there are non-hemolytic strains of GPS as well. They're typically large colonies with small zones of hemolysis, and this is in contrast to Group A Strep, which has a larger zone of hemolysis that can be seen on the blood agar plate. And some strains can also be pigmented orange. The history of Group B Strep is it was first isolated in 1887. And in 1935, it had been known to be associated with pregnancy and early newborn sepsis. In the 1960s, there had been a noted increase in newborn infections with Group B Strep. And in the 1970s, it had emerged as a major cause of sepsis and meningitis in newborns and neonates. And then by the 1990s, we started using antibiotics during labor to prevent the spread of Group B Strep from mother to infant. And in 1996 specifically was the first time there were consensus guidelines published on how to prevent Group B Strep infection. And then in 2002, they had updated those consensus guidelines, and we are still using the criteria where we have universal screening for Group B Strep, as well as the utilization of antibiotics for mothers who screen positive and using the antibiotic during labor. So all people are reservoirs for Group B Strep. Hosts are neonates, children, women, and men. We all carry it in specifically the lower gastrointestinal tract, as well as in the genital tract. It's noted in studies that the range of 5 to 40% of women are carriers of Group B Strep in the genital and GI tracts. And the reason why we care about this is because Group B Strep can be passed from mother to baby during labor and birth. So there are both peripartum infections of the mother as well as the infant. The Group B Strep can colonize the infant by ascending route at the time of delivery. So about 50% of infants will be colonized with Group B Strep. at delivery, and 1 to 2% of those babies will develop infection. Types of infections that adults can have are perinatal associated infections such as miscarriage, stillbirth, or preterm birth. Non-perinatal infections include bacteremia, pneumonia, skin and soft tissue infections, bone and joint infections, and urinary tract infections, Neonates classify 2 different types of infections, either early onset or late onset infection. Early onset is defined as being less than 6 days, which is the most common type of infection for neonates, and that includes sepsis and pneumonia. Late onset is defined as being 7 days or greater, up to 90 days or 3 months, and that is primarily seen with meningitis as the main type of infection for late onset disease. Risk factors are many. They include testing positive for Group B Strep late in pregnancy, having a positive urine culture with Group B Strep during pregnancy, having an early delivery, which is defined as less than 37 weeks. If you develop a fever during labor, that's increased risk for GBS. If your membranes rupture greater than 18 hours before delivery, that's also an increased risk. Maternal age younger than 20 years of age, or history of having a previous baby who developed onset disease, early onset disease. So lots of risk factors for this infection type. So the symptoms for early onset Group B Strep are rapid breathing or stopping of breathing, making grunting sounds, poor feeding, if they're abnormally drowsy, having a high or low temperature, having a high or low heart rate, and low blood sugar. So 2/3 of Group B Strep babies will develop early onset disease, and 90% of them actually will show symptoms within 12 hours of birth. So this happens pretty quickly. Late onset symptoms include being irritable with high-pitched crying or whimpering. They may have a blank stare, trans-like expression on their faces. You may have floppy baby or not liking to be handled. They may turn away from bright light or involuntary, stiff, or jerky body movements. Late onset disease is uncommon after a month, can happen up to 3 months, but rare after that. So anything greater than 3 months, you should consider yourself kind of in the clear and out of the woods. So our methods for prevention mostly target early onset disease. We give antibiotics during labor to mothers who screen positive. And unfortunately, there's no prevention methods for late onset disease. Basically, they say that symptom recognition is essential and early treatment is vital to help the babies overcome these infections. So in the US, we take a screen-based approach. Other countries take a more risk factor-based approach. So we do universal screening between 35 and 37 weeks of pregnancy. The specimen collected is a vaginal rectal swab, and antibiotic prophylaxis for positive mothers is given during labor. When the risk factor-based methods are used, these are pretty much the same risk factors that we mentioned earlier. And previous to our current screening, we basically used both types, but data suggests that the screening-based method is superior to the risk-based method, so therefore in the US, we primarily focus on the screen-based method. So here's some nice data that shows the effect of prevention on the incidence of GBS infection per 100 or per 1,000 live births. So for early onset disease in the solid line, you can see that in the 1990s, as we mentioned, the rates were very high. And then once the consensus guidelines came out in 1996, there was a significant drop in the incidence of infection. And since then, since the revised guidelines in 2002, we've seen even more continued drop. and we've kind of plateaued now because we basically are using the same methods that we were using back then. As you can see, the late onset incidence has remained the same because, as I mentioned before, there are no ways to prevent this from occurring. So now we'll move on to quickly review the laboratory methods for GBS detection. So the gold standard is still culture. There are different augers that you can use, either blood auger looking for hemolysis or selective auger that help to make the hemolysis more obvious. There are enrichment broths that help to select for Group B Strep. You can see here on the bottom left, we have the enrichment broth where you see a color change for a positive and no color if it's negative. The different broths include carrot, limb, and trans veg. So if these are positive, we can then go back and plate them to the blood auger and culture those. Agglutination method is still determined or listed as the best way to identify Group B Strep. So here you can see we have Group B and Group A, and these are the type, Lancefield type agglutination. So Group B agglutinates when that's the Group B antigen, and Group A to Group A. So why we're all here, right? What you've all been waiting for, to discuss the performance data of the Simplexa Group B Strep Direct. So in the clinical validation study, there were 432 specimens included in the study to evaluate the performance of the Simplexa GBS Direct assay, and this was in comparison to culture. Culture included both selective and non-selective blood auger. Group B Strep was confirmed by gram stain, catalase, and latex agglutination. The clinical agreement here, you can see that the assay sensitivity was 97% with a 95% confidence interval of 91.5 to 99%, and the specificity was 96.1% with the 95% confidence interval of 93.4 to 97.7%. Of the discrepant results, they were refereed by another FDA-cleared nucleic acid amplification test. So basically the routine method of the performing laboratory. And all samples here correlated with the Simplexa data. Similarly, here we had 13 discrepant results, and of those 13, 11 nucleic acid amplification tests or alternate method correlated with the Simplexa. More specifically, here's data from our site. So we were site 6, and although we were the smallest data set that was included in the data that was submitted to the FDA, we had the highest prevalence of Group B Strep at 30.4%. The mean prevalence was 25.5%. The clinical agreement for the Geisinger site data, we saw 100% sensitivity and 97.5% specificity. There was one discrepant sample, and when we tested it on the Cepheid Gene Expert, which is our routine method for GBS detection, that correlated with the Simplexa. Okay, so here's the CE mark data. So just to remember that the assay is not FDA approved yet, but soon to be. Any minute now, right, Michelle? It is CE marked. So the CE mark data that was used is different from what was submitted to the FDA. So here, the specimens were tested using the Simplexa assay, but compared to other CE marked nucleic acid amplification tests. And in this case, culture was the referee. So here you can see that the positive percent agreement is similar to the FDA data at 97.1%. And then the negative percent agreement, is 99%. So all of the discrepants were basically correlating to the Simplexa assay. Here's the Geisinger data for the CE mark. In this data set, we had 94.1% positive agreement, or positive percent agreement and negative percent agreement of 94.1 and 97.4 respectively. And again, in the discrepant data, we performed culture, and the culture correlated with the Simplexa direct. The analytical validation included limit of detection, which will be referred to as analytical sensitivity in the following slides. It included reproducibility, analytical reactivity, cross-reactivity, microbial inhibition, and interfering substances. The analytical sensitivity of the assay for two ATCC strains were at 30,000 colony-forming units per microliter and 80,000 colony-forming units per microliter for the other strain. For reproducibility, total reproducibility, the percent CVs for both the GBS and internal control channels were less than or equal to 3.2% CV, and the interlot reproducibility was less than 1.2% CV. For reactivity, there were 18 different GBS strains that covered multiple serotypes and included non-hemolytic strains as well. And all 18 strains were positive at a concentration of 110,000 CFU per mil. For cross-reactivity, there were 74 different bacteria, viruses, and fungi that were included in the studies, and there was no cross-reactivity observed with any of the organisms. And in the next slide, I believe we have listed all the organisms. There were 3 organisms that were analyzed via their BLAST in silico analysis because they were not available for testing. And for the microbial inhibition, none of the organisms similarly observed any inhibition. So this is the large list of organisms. I know it's very small, but again, none of them showed cross-reactivity or inhibition of the assay. For interfering substances, this included 26 potential interfering substances when spiked into the GBS ATCC strains that we had seen previously with the LOD, and these were at 2 times LOD. Of these 26, 8 substances showed concentrations that were interfering, and it's very small here, but there were mostly they were medications included, and these were all at very high concentrations. So when the concentration was lowered, then they were able the assay was positive, so they were able to detect the level at which these compounds did not interfere with the assay. Okay, so in conclusion, we know that GBS is still a leading cause of neonatal sepsis, basically worldwide. It's not solely restricted to the United States. We have universal screening for intrapartum antibiotic prophylaxis that are the foundation of our preventative methods. And the Simplexa Group B Direct is a rapid, it is a 65-minute turnaround time. It's a rapid method, an accurate method that can be used to screen pregnant women for the colonization of Group B Strep prior to delivery. And again, the sensitivity was 97% and specificity at 96%. So with that, I'd like to thank Dr. Donna Wolk and the rest of our research team. I'd also like to thank DiaSorin for inviting me to speak to you today, especially Dr. Michelle Tab and Tiffany Monreal. And with that, I'll take any questions. Thank you. Yes.
Did you enrich the samples at 18 hours and then raw, for example? Do we, regulations still recommend high reading that's done before?
Yes. Yes. And that's, I think, same for all of the approved assays that are out there. Yeah. Yes?
I don't know if I missed this, but did you use both the vaginal and rectal swabs for the problem?
Yes. No other questions? Okay, thank you.